And with these sessions, we are completing our 3 years of TUGSS India academic program. So, with this today, with my colleagues, with my co-host, I welcome my co-panelist, Dr. Abhishek Gangopadhyay, who is Assistant Professor in Department of Surgical Oncology in Chitranjan National Cancer Institute, Kolkata, and Dr. Exit Mishra, who is a consultant surgical oncology in Desul Cancer Institute in again Kolkata. Both have organized today's event, which is based on the gastrointestinal stromal tumors, which is really a very less discussed topic, and I hope it may be useful for all the delegates, all the attendees. So, with this, I will like to hand over my mic to the Dr. Abhishek, who can introduce our first speaker and carry on the program. Dr. Abhishek.
Yeah. Hello, good evening, everyone. Am I audible?
You're audible.
So, we'll start our discussion on gastrointestinal stromal tumor today. So, we have our faculties with us. Dr. Manas will be joining soon. And to begin with our session today, I'll invite Dr. Ramanuj Mukherjee, who is Professor in Surgery, Archikar Medical College, Kolkata, to start on the diagnosis and symptoms of gastrointestinal stromal tumors.
Am I audible, everyone?
Yes, sir. You're audible.
Okay. Right. Am I audible now? Is the screen visible?
Yes, sir. Everything is fine.
Okay. Right. Can I start now, sir?
Definitely.
I think there is a scratch, a gentleman that scratched on the screen. Okay. Please notify me when I can start.
You can start it now, sir. This sketch sometimes some delegates used to interfere in the program. I'm sorry for that, but you can start it now.
Okay. No issue, sir. Thank you, sir. I'll start now. A very good evening, ladies and gentlemen. It is technically an honor to be invited in this podium to talk about particularly a topic that I really like to talk about, because the evolution of the disease and the evolution of the topic has made us very close to something called as basic biology. Now, before we start on, I think greetings from the city of joy, the Kolkata, and as we start with the evening on a very important topic, probably which has evolved for the last around 20 years, something called as gastrointestinal stromal tumor. What I would like to talk about is technically something which has evidence and something which is backed by literature, not only our thought or our likings. Now, I will be very brief to the topic. And to begin with, gastrointestinal stromal tumors, to the best of our understanding, for around 3 decades, since the gentleman called Mazur and Clark started by coining the term called GISTs, begin with something called as interstitial cells of Kayal. When interstitial cells of Kayal, as you can see in this one, are usually spaced around the muscular wall of the bowel. We're talking about endoscopic ultrasound. You will get to see these layers more clearly. But for anyone who is uninitiated, these are those groups of cells which are present with some known, some unknown functions in the muscle wall, particularly with a neurotransmitter and a pacemaker functions, which are attributed to, but there are more myriad functions like proliferations and more amount of gastrointestinal hormonal secretions by these cells which are attributed to. Now, what is very important is that the integration of gastrointestinal stromal tumors has been done by clinicians not only understanding that this is a new thing that they have to learn with. Number two, they also need to understand that there is a good amount of treatment that are available for the diseases that are there. Now, so to summarize, understand mesenchymal technically have is as it will be done for the next couple of what is very important for us to understand is that the main driving mutations that will accumulate or will account for gastrointestinal stromal tumor will be something called as a c-KIT mutation in FRA. So if it is not c-KIT, then it is probably a PDGFRA. Now, if you have ruled out a PDGFRA and a c-KIT, then probably the only thing that remains is something which is hereditary, called as a succinate dehydrogenase. But again, those are rare things, and we'll not be talking about rarities in today's evening. We'll be talking about what 90% of gastrointestinal stromal tumors are. They're either c-KIT or PDGFRA mutations as drivers from this. Now, so what is so special about these ones? The special about these tumors are that these tumors will arise from the bowel wall, usually, as we'll talk about the rest of the disease. And when they will start from the bowel wall, they will either make the mucosa very congested to begin with, ulcerated in some places, and to be the most common manifestation, particularly in the most common site for the stomach. Now, some of the genetic rectum and esophagus to be rare places where again tumors like this, rather than bleed, because of the size of the tumor and because of the slow growth, they usually don't to obstruct the rhythm of the bowel. Now, what is very interesting, and as a clinical fellow, right? So now what becomes very interesting is that the biology of the tumors and the biology at which the disease does progress makes the addition of targeted agents like tyrosine kinase inhibitors, which are important if an NACT or neoadjuvant chemotherapy is being planned. But what I will be talking for the next couple of minutes is that the scenarios in which it does produce a problem. Now, as I have said before, also, ladies and gentlemen, that the biology determines all in a gastrointestinal stromal tumor. Now, in a gastrointestinal stromal tumor, as you can see that the majority of the cysts are known to occur in the stomach, followed by the small intestine, followed by the rectum in the GI tract. Now, beyond this, there are other sites beyond the GI tract, which are called as extra intestinal cysts or extra GI cysts. But what is very important is the percentages, and this is a Nature article. So please keep that in mind that this is an interesting landscape of the genetic mutations that we do have, because this exon 11 and the exon 9 mutations will require you to think about the dosage of the imatinib that is being used. So what is important is that, as you can see, the most common mutations will always be in exon 9 rather than in exon 11. Whereas in small bowel cysts, around 25% will be in exon 9. Now, so I have been harping on for the last around 3 minutes on the same topic, that yes, that cysts are an important disease to understand. But what is more important for a clinician to understand is that rather than talk about an adenocarcinomas or maybe a neuroendocrine carcinomas, this end of a gastrointestinal stromal tumors are technically a curable form of a cancer. So, and majority of these will have the surgery as a first line of treatment. So, for all the purposes that we do remember, gastrointestinal stromal tumor should always be approached with a very strong curative intent in mind. Now, so whenever we talk about these, and my next of the speakers will be talking about these, you will have discussions about what is a good anatomy like this one, where you can take out a sleeve of stomach or something near the GE junction, which will have a very difficult perioperative period if you do not take out. But what we will also be talking, and the rest of the speakers will be, as I have said, when you talk about the clinical diagnosis, we will have to talk about that what should be the good biopsy to begin with. Now, rather than when we talk about the biopsy, what will be more important will be knowing about something called as the biology of the gist. So in this the next minute, I will present to you three patients, and they are real life patients, in which we will talk about the first patient to be a 34-year-old lady who had a recurrent episodes of vomiting. As you can see on an endoscopy, we found that there was a bulge in the lesser curvature, with the rest of the mucosa which appeared normal. Now, for those who are residents in training or those in practice, please remember that the rest of the mucosa gives you a very good idea about what the disease is. A central ulceration, which is more or less pathognomic of a submucosal tumor. And this group of tumors nowadays are called as subepithelial tumors. And this group, interestingly, should always be examined with something called as an endoscopic ultrasound. Now, whenever we talk about the endoscopic ultrasound, or whenever you talk about these as the gold standard, what is important is that there are two probes in which we will usually be using something called as the curvilinear or the circular probe rather than the linear probes which are used for a biopsy. The biopsy needles are usually of a 22 gauge, and in this new generation of an endoscopic ultrasound, we use something called as a contrast in an endoscopic ultrasound, in which you can see the area where you can target your biopsy from, because these tumors are known to have a good amount of necrosis in them. So, if you like to summarize, the first diagnosis or the first line diagnosis of a suspected GIST, particularly of a stomach, will always begin with doing an endoscopy, followed very quickly by thinking about always doing an endoscopic ultrasound. Can you take a blind biopsy as I had asked you about doing this? Yes, you can. It is not that you cannot, but it is always the gold standard to use an endoscopic ultrasound to take a biopsy, particularly with these eras of doing a contrast enhance to guide your biopsy. Now, when you are talking about an endoscopic ultrasound, remember that we have a brevity of time and hence we will not be talking about this. The fourth layer, the muscularis propria, as you can see by this highlight, is usually the layer where cysts, leiomas, and schwannomas start. So, what is the difference between them? Believe me, ladies and gentlemen, to a surgeon like me and a tumor that bleeds or tumor that obstructs, the rest of the thing will be a bit theoretical because everything has to come out. We are certain something that we do not like on imaging or does produce symptoms, it does come out of the body. But what is very important is that if you are planning for neoadjuvant therapy, probably just as you can see on this one, which appears hyperechoic on an endoscopic ultrasound, does need to be thought about with a preoperative imatinib. So when you think about what can be very different from a GIST, remember that adenocarcinomas can occur in any place. But what is very important in the ulcer of an adenocarcinoma are usually with an everted margin, whereas the rest of the GIST tumor will have, as I've shown you 2 slides back, with a big submucosal elevation, and then there is a small inverted ulcer. Induration, that means with an endoscope or with a clinical, is very typical of an adenocarcinoma, sometimes even a neuroendocrine tumor. Whereas lymph nodes are very typically absent in a GIST. There are a few variants like a succinate dehydrogenase where you may get lymph nodes. But remember that lymph nodes, if you think of any, should always make you think of more in the form of a carcinoma, neuroendocrine carcinoma rather than GISTs. Now, what is very important for you to document is the size of the cyst. Because as I have shown you, more is the increase in the size, more is the increase in the mitosis. And believe me, this is the most important prognostic factor. And out of all the sites, both stomach and the ileum, what becomes very important is this landmark article, which does iterate again that the size of the gist does matter, and as Godzilla says, the bigger the size, the more worse it gets. Now, if you think about the NCCN guidelines, again, what is very important in gist stratification in the predicted biology of mitosis, again, ladies and gentlemen, is the size. So the bottom line is whatever you think of, please remember size is important. Now, when you get a biopsy done, and I hope you remember the gentleman called Raymond Kayal, I really like the Google Doodle about Raymond Kayal, in which our understanding of just around 120 years back, or as we celebrate around 160 years of the gentleman's birthday, what is very important is that the GIST tumors, you will usually go by a series of immunohistochemical marker, and the first of the markers will usually be CD117 or the CK. CD34 is not a very strong, sensitive, or specific marker, but DOG1, that means it was detected on a GIST1, is one among the most specific and sensitive markers for a GIST. Now, what is very important is that beyond a log1 CD34 markers, then other gene mutations like a PDGFRA will only be done if these markers are negative. And if everything comes negative, you should really think about your diagnosis, because if you talk to your pathologist, they are going to suggest you other tumors or markers like desmin and schwannomas in this. So this is more or less a very abbreviated algorithm on how we should approach a GIST immunohistochemistry. The great mimics that we have been fooled, believe me, I have been fooled twice in my life, once with a lymphoma, once with a NET, is again when your immunohistochemistry is not suggestive and you have other options like a lymphoma and a NET to talk about, in which they will only be predictive. Now, once you have diagnosed a GIST, the next stage you need to stage. The most important imaging investigation will always be a CT thorax abdomen and sometimes even the pelvis, in which you need to see the extent of the GIST, the relationships, and most importantly, whether it is metastatic to the liver, rarely the lymph nodes. And as I've said, lymph node GIST will rarely be a differential diagnosis. Now, as my next of the speakers will be talking about, but one of the important things, please believe me, in a GIST in this era is a very simple slide. Think of the biology, correlate the anatomy, correlate the behavior, correlate the clinics, and then think of what is your planning, because the next of the treatments and your decisions will be dependent upon something called as the role of neoadjuvant. So I hope my next of the speakers will again be talking about neoadjuvant, but the very bottom line of a neoadjuvant is very simple. I simple make this 2 by 2 table. Either you have a good anatomy with a good biology, go for an upfront. Bad anatomy in a good biology, think about neoadjuvant. Whereas the next of the ones will be thinking about a potential organ preservation. If you're thinking about a neoadjuvant, then your decision should always be a preoperative imaging, particularly in a rectal gist where bad anatomy and sphincter preservation should always be kept in mind. And please believe me that when it is a sphincter preservation story, please think about a neoadjuvant. Preoperative imaging should always be taken into account what are the things that you want to see for your tumor response assessment. PET, believe me, as I will be talking about, is studies like the ACRIN study, which talked about the PET. But what is important for everyone to remember are the response parameter. Like the CHOI response and the modified CHOI became an important thing about predicting this. And this is something that we use. But you can use other WHO criteria, but this is a standard one that you use for this. We now wind up the discussion with a second case discussion about something called as a small bowel gist, in which they will usually be presenting with an obstruction. And on a laparotomy, believe me, they will usually be a surprise because your CT scan had a doubt. CT scan people told you that yes, it could be a gist, but now the problem is that should you take out a lymph node or not? We now took out the mesentery, which believe me is always, if you think of a lymph node in the drainage territory, probably it's not a gist. You are dealing with a lymphoma or an adenocarcinoma, maybe neuroendocrine, but gysts will usually be rising with a polypoidal swelling producing an intersusception or a tumor block. Now, I gave this slide, I'll pause it for a second or so. The slides are with the gentleman. So you can have a differential diagnosis in which gysts will always be an exophytic mass rather than an endophytic. Lymph node metastases are uncommon. Desmoplastic reactions are very uncommon. The third case, and I end this discussion, ladies and gentlemen, today are gysts which are neither of the stomach nor of the intestines, but are something called as, in which you have those abstract areas, and it does come to you as a surprise. You took a core biopsy from a retroperitoneal tumor or a mesentery, and you say, oh my God, pronto, I got a gist now. So please remember that talk to your pathologist that whether their diagnosis is right. And what is very important is think about what kind of a treatment that you are going to offer, because widely metastatic or retroperitoneal cyst in bad locations are sometimes very, very difficult. This group, something which has been called as an e-gist, is technically around 10%, as I've said, the 90% is taken, are really peripancreatic, mostly in locations, but again, literature is very scarce. People have very small series. The maximum that I could find is 138 cases. And but there is a big role, ladies and gentlemen, for something called as an imatinib, which is used to make it resectable. But what is very important for surgeons to remember is that yes, we offer an R0, but even R1 could be done. My last slide, ladies and gentlemen, and I end now. What is very important, ladies and gentlemen, is that in this sort of an endoscopy, which is used so commonly, we now are getting incidentalomas or gysts which are silent. There are terminologies like micros and minis. And what is very important is that endoscopic ultrasound has predicted that yes, if you do have no necrosis it is homogeneous. There is no cystic spaces to think about. In the tumor, it is smooth. Probably you can think about an observation with a serial endoscopy. But the only place that we do not usually follow that is the rectum, where the growth can usually be a cost to the sphincter, and the rectal cyst should usually be taken out. Finally, ladies and gentlemen, to conclude, a diagnosis and a dilemma in GIST will usually be always a combination not only of an endoscopy but endoscopic ultrasound, a tissue biopsy with an immunohistochemistry, a good surgeon, good pathologist, a good gastroenterologist. Tumors will usually be presenting with a bleed or obstruction, and in this era of a targeted therapies of going up to 4 lines, it is important that we thinking about an NSCT and monitoring. So before we end, ladies and gentlemen, I think the diagnosis of the GIST and probably the crux of today's discussion and the title that I have is thinking about how to diagnose and how to think about how to use your diagnostics. Please remember that what we do need in the diagnosis is very common sense. So if you think about, I come from a family of engineers, and hence one of my family members into these videos about, you must have a practical thought about in your hospital, in your scenario, about how you are planning to diagnose a GIST. Do you need an endoscopic ultrasound in all the cases? Do you need a genetics in all the cases? Probably no. So some cases, yes, you will need a genetics to say. But in rest of the cases, please use your diagnostics logically. If you're thinking about a GIST and planning for an imatinib, please use a biology assessment and use your diagnostics tools very logically and technology logical. With this, ladies and gentlemen, I think I will be now finishing up, ending the slides. And again, thanking you for the opportunity to be a part of your awaited group. With this, thank you, everyone. Thank you very much.
Thank you, Professor Ramanujan Mukherjee, sir. Our next speaker is Dr. Ismail Banerjee.
So, am I audible?
Dr. Nirmal Banerjee is a consultant histopathologist at Narayana Hospitals and Disan Hospital, and he is an ex-alumni of PGI Chandigarh, where he completed his MD pathology and DM histopathology. Dr. Nirmal Banerjee would be speaking on the pathology of GIST. Dr. Nirmal Banerjee.
Yeah. So, am I audible, everyone?
Yeah. Yes.
Yes, you are audible, sir.
Okay. So, my slides are visible, I guess.
Yes, it is visible, sir.
Yeah. So, good evening, everyone. So, today let's summarize the diagnostic protocol of GIST, and let's discuss it with the clinicians who are there most of the time. Like, what are the informations to be conveyed to the clinicians, and what are the things should be mentioned in a standard histopathology report. So, to start with, I want to start with the basic fundamental fact of GIST. Like, it is the most common mesenchymal tumor of the GI tract, and majority of them are sporadic. That means there are syndromic GIST also, right? And adult GIST, it is very important to understand that they harbor mutually exclusive mutation of so-called c-KIT or PDGFRA gain of function. So either KIT or PDGFRA in majority of the adult GIST you will get. Majority means 85%. Whereas pediatric GISTs are usually negative, which we also call as wild type GIST. And these mutations help not only in diagnosis, but also in risk stratifications and act as a predictor for treatment assessment. So with this background information, let us start with the cell of origin. Now, cell of origin is very important because we detect those markers according to the origin of the cells. Now, if you look at the interstitial cell of Cajal as described by the previous speaker, it is located around the circumference of the mesenteric plexus. Now, if this is the mesenteric plexus, the periphery will be dominated by the pacemaker cell or interstitial cells of Cajal, which are dominantly demarcated by CD117 immunostain. So this is the cell of origin of the gist. Now let's come to the basic pathology, the mutations, the downstream signaling pathway, and the molecular pathways. Now, see, the KIT or PDGFRA are the so-called receptor tyrosine kinase type 3. They're located everywhere in our body, and they constitute three parts. One is the extracellular part, one is the transmembrane part, another is the intracellular part. This acts for same for both the type of receptors. However, the functional domains are five. One is the extracellular domain. Beneath this, there is a regulation of dimerization domain, followed by juxtamembrane domain, and then ATP binding residue, and the tyrosine kinase activation loop. So these five fundamental functional areas are same for both the transmembrane receptor, and they are encoded by the proto-oncogenes. Now, what exactly happens when the pathogenesis of GIST start? Now, nowadays, in the era of NGS, we have every data to stratify, to localize where the mutation starts, which are the drivers mutations, and which are the less common mutations, or you can say the passenger mutations. Now, it has been seen that exon 11 is the most common mutation in the KIT receptor tyrosine kinase, and it is located in the juxtamembrane domain, followed by exon 9 mutation. Now, why exon 9 is important? Because it has been noted that exon 9 mutation is most commonly located in the lower GI tract and usually associated with aggressive behavior. Similarly, exon 17 and 19 are associated with diffuse spindle cell morphology, and exon 13 mutations are mostly located in the stomach region and are usually aggressive in nature. Similarly, PDGFRA exon 18 is the most common mutations. As compared to KIT mutations, PDGFRA mutation behaves relatively better. However, they also show epithelioid morphology and can be associated with gastric region location. So this is in short what the mutations are, the common mutations are, and exactly which are the exons we need to look for. Now, irrespective of the locations, like the previous speaker has mentioned, gastric gist are the commonest gist, followed by small intestine, followed by the rectal and esophageal. Now, whatever be the locations, KIT exon 9 and 11 are the common, and PDGFRA exon 18 mutations are common. So they should be in the target panel. Now the headache starts from here. Once the clinical diagnosis is GIST, the morphological diagnosis is probably GIST. However, you are not getting neither KIT or PDGFRA. In those situations, we label it as wild type GIST. Now, once you are confirmed it is wild type GIST, your job is, as a histopathologist, or our job is to do an IHC, which is known as succinate dehydrogenase, or SDH. It comes in two isoforms, SDH-A or SDH-B. Now, the mutations in these genes coding for SDH, it can be epigenetically mutated of suppression of the SDH, which is known as the SDH deficient gist. Why I'm emphasizing on those two terminologies, I will come later part of my presentations. And the SDH competent genes are also known as the mutations related to RAS, MAKE, and MAP kinase pathway. So if you are dealing with a wild type gist, then the next step should be SDH. You can see the internal controls are positive, where none of the cells are showing SDH mutations. Whereas in the right hand side, you can see the diffuse granular cytoplasmic reactivity of the SDH, which is showing SDH competent GIST. Now, if in a suspected case of GIST, you get neither KIT, PDGFRA or SDH, you can label it as quadruple wild type GIST. Now, in those cases also, in particular these cases, NGS helps, and it has been noted like PIK3CA, NTRK, and FGFR1. These genes are commonly mutated, and tropomyosin receptor kinase inhibitor, they are useful in these type of GISTs. Therefore, the genetics and the epigenetic mutations directly related to the therapy, and these mutations should be included as far as the morphological type and the genetic subtypes are concerned. Now, the clinical features depends on three factors: site, size, and location of the tumor. However, the most common symptoms are bleeding, abdominal pain, and the weight loss. Coming to the gross pathology, most of the time as a surgical pathology, we receive the excised specimen. Now, most of the time, the GIST present as exophytic submucosal bulge like this. This is a partial gastrectomy specimen. And on cut sections, we see the smooth, glistening, yellowish white surface. Sometimes on a large small intestinal GIST, we get this sort of cystic degenerations, necrosis, intratumoral nodule, like this kind of thing. Coming to the histopathological patterns or the morphological patterns, we divide it into two broad categories, whether it is spindle cell type or it is epithelioid type. Now, spindle cells are again divided into the sclerosing type, sarcomatoid, hypercellular, or with the myxoid-rich stroma or stroma-rich GIST. In case of epithelioid type, they can be sarcomatoid also and the sclerosing epithelioid GIST also, which are very rarer entities. In this panel of photomicrograph, you can easily see these type of GIST, which is known as the sclerosing spindle cell GIST. These type of GIST very closely mimic malignant peripheral nerve sheath tumor. It is morphologically a close mimicker. Similarly, the other spindle cells variants, they mimic the other spindle cell sarcomas like leiomyosarcomas and others. Similarly, the epithelioid GIST, which are more of an aggressive in nature, they are comprises of large epithelioid looking cells with frequent mitotic activity. So in this, having said this, I also wanted to mention the one more type of GIST, which is also known as de-differentiated GIST. Now, why I am saying this? Because in this type of GIST, transition from a morphologically low grade to an typically anaplastic or transition to a pleomorphic high grade has been noted, and intratumoral heterogeneity has been detected in this type of tumors. And most of the time, even after doing CD117 or KIT immunostains, we get loss of immunostain off. But it should be noted that de-differentiated GIST can happen. It can occur de novo or can be after starting the treatment of the imatinib or the tyrosine kinase inhibitor. And most of the cases, it has been advised by the WHO also, like extended sampling is the only way out to rule out any other tumor and to diagnose the de-differentiated areas. Now, coming to the most important part of the discussion, what should be the IHC panel? Now, what I prefer, I used to do in the first go 5 markers comprises of CD117, DOG1, CD34, Desmin, and S100P. Now, everybody knows nowadays, like GIST is positive for c-KIT or CD117. DOG1, which is another immunostain, which is the full name is demonstrated on GIST, is also positive. It is a co-positive marker. It reconfirms your diagnosis. But the role of Desmin and S100 is of immense importance because Desmin is a connective tissue marker. It comes positive once you are dealing with a smooth muscle tumor or any tumor of connective tissue origin. Similarly, S100 is a neural marker. Once you are dealing with a nerve sheath tumor like neurofibroma, schwannoma, some malignant nerve sheath tumor, this comes positive. Therefore, it is necessary to rule at the first go whether you are dealing with any other tumors. So therefore, these two markers has to be included in the IC panel. Now, it is not always easy to diagnose GIST based on CD117 because there are altogether 4 patterns have been described by the WHO and the textbooks. One is the diffuse cytoplasmy, which is the most common pattern, followed by perinuclear dot-like pattern and the crisp membranous, and sometimes focal and weak reactivity of CD117 has to be taken seriously, and the further immunostains like DOG1, CD34 should be done to reconfirm your diagnosis. Therefore, to summarize, I want to mention like spindle cell tumor, having KIT and DOG1 reactivity, then the life is easy. Then possibly you are dealing with a GIST. When it comes negative, the role of desmin, SM, am I audible?
Yeah, you're audible, sir.
So the role of desmin, SMA, and H-caldesmon are of immense importance to rule out smooth muscle origin tumor. This has to be included in your panel. Another most notorious mimicker, which I'll be discussing in the next slide, is the inflammatory fibroid polyp. Most of the times, it basically disturbs a pathologist's mind whether he is dealing with an inflammatory fibroid polyp, which is an utterly benign tumor. Let me tell you, it is an utterly benign tumor, but morphologically very closely mimic with the GIST. And most of the time, colonic small biopsy, we get this sort of inflammatory fibroid polyp. I am coming to it in the next slide. Similarly, in case of epithelioid GIST also, if it is KIT and DOG1 negative, please rule out whether you are dealing with any sorts of picoma or some melanotic tumors. You have to do HMB45 or Melani to rule out this. Now, as I have described earlier, inflammatory fibroid polyp is a mimicker of GIST. It's a benign mimicker. It's a benign tumor. Now, what are the morphological clues to diagnose IFP? Now, IFP is a small to medium size. It never crosses the size of 5 centimeter. It is most of the time located in the lower GI tract, and on low power, you will get this sort of morphology like bland spindle cells with occasional atypia. However, on the high power, you will get the tumor cells are concentrically arranged around the venules. So this sort of typical concentric arrangement is a very pathognomonic of inflammatory fibroid polyp. But this is not good enough to diagnose because sometimes GIST can also produce this morphology. So CD117 has an immense roles because most of the time CD117 becomes negative in case of IFP, whereas CD34 becomes diffuse and strong positive. In spite of all this, if you have any doubt, you can discuss with the radiological counterparts, radiology reports, or your clinical counterparts to rule out whether you are dealing with an IFP or you are dealing with a spindle cell GIST. Now, in a case of wild type GIST, where, as I have described earlier, the role of SDH is important. Now, the another wing of this, SDH helps us to detect whether we are dealing with a sporadic GIST or a syndromic GIST. Because if the SDH is positive, most of the time you are dealing with a sporadic GIST. Because SDH negative GIST, which are associated with syndrome, it can be associated with your paraganglioma, may not be associated with the paraganglioma, but it is of a Carini syndrome related, where the prognosis is much more grim, the tumors behaves a more unpredictable manner, and often it shows typical sarcomatous behavior like invasion to the local organs. Therefore, it is also important to know whether you are dealing with a syndromic GIST or sporadic GIST based on the SDH immunostain status. Now coming to the risk stratification, this is which is more important and has to be included in your histopathology report. Now, whenever reporting a GIST, two things should be kept on mind. Whether you are dealing with a larger GIST, larger means it's a relative term. There are data in the cap where the GIST, the size of the tumor, according to the location of the tumor has been segregated, and the mitosis in the 5 millimeter square. Now, again, I am emphasizing on the term. The 5 millimeter square is a very confusing term. In the modern day Olympus microscope, you just count 20 high power field. And let's see what is your highest mitotic figures on the paper. So based on these two data, the size of the tumor, the mitotic rate on 20 high power field, 20 subsequent high power field on a single slide, then you start your risk stratification, and it has to be mentioned in your histopathology report. What else has to be mentioned in the histopathology report? One is the tumor size. Number 3 is the mitotic rate, tumor necrosis, not the infarction necrosis, tumor necrosis, the percentage of tumor necrosis, histological grade, and the risk assessment. So that completes your report, the histopathology report. Now, nowadays, the molecular analysis has to be done in addition to the IHCs. So the KIT mutations should include exon 9, 11, 13, 17, and 12 in the standard molecular pathology lab, and PTGFRA exon 14 and exon 18. Now, again, there is a conflicting data. Which one should we prefer? Should we go for ddPCR, digital droplet PCR, or NGS? Now, to me, digital droplet PCR is much more accepted because of it's almost 100% specific and 95% sensitive. You can see the data. The ddPCR data and NGS data are almost comparable. In fact, in some cases, it is even more sensitive. And the most important is it is cost effective with a shorter turnaround time. So if the histopathology lab or the molecular pathology lab has the ddPCR, he or she can easily provide the report within 7 days with the all sort of KIT and PGFR acceptable mutations in the report. So with this, I want to conclude with the take-home messages like spend time with the slide before you dispatch a report of GIST because it's a malignant tumor. Careful examinations and small biopsies should be taken very seriously because the mimickers are huge. You never know, you might miss a leiomyoma. Therefore, correlation with the radiological and endoscopy report is extremely important. Don't forget to risk stratification of the large excised sample, and IHC is of utmost importance to confirm the diagnosis. It has to be done. And those primary markers which I have mentioned has to be there in the report. And the extra importance to be provided regarding the role of ddPCR, you have to really tell your clinicians like ddPCR is there and NGS is there to detect the the driver mutations or uh, the exons mutations which we are expecting. So thank you very much.
Thank you, Dr. Nirmalo, for your detailed and brainstorming session on the diagnostics of GIST. I'll hope the surgical principles of GIST will not be as difficult as to landing up in the diagnosis of the GIST campaign, which is literally true. So I'll invite Dr. Professor Manas Ranjan Sahu sir, who is Vice Chancellor, Odisha University of Health Sciences and Professor and HOD of Surgery, AIIMS Bhubaneswar, to talk on the surgical principle of GIST. Manas sir,
Dr. Manas, please unmute yourself.
Dr. Nirmal, you have to stop sharing the
Yes, it's
screen.
fine. It's fine. Got it. Am I audible now?
Yes.
Yes, sir. Yeah.
Right. So I think after that, sorry, after the diagnosis and pathology of GIST, probably now it's time that the scalpel need to be welded for this gastrointestinal stromal tumors. I think for any GIST surgery, the most effective treatment for a primary GIST, regardless of the location, is the radical treatment, radical surgical treatment. And the aim is always a macroscopic and microscopic negative margin. An R0 resection like any other malignancy. And the recommended margin is 1 to 2 centimeters. So microscopically negative margins always actually increases the chance of better survival without relapse. Generally, reoperation after R1 resection is not routinely recommended because most of us, when we operate and there is suppose a R1 resection, nobody actually goes for a re-surgery in a GIST. Risk of tumor capsule damage and neoplastic cell spread should always be minimized. That is probably the most catchy thing that a surgeon while dealing with a surgery for GIST should always remember. And GIST predominantly grows under the mucosal layer. The mucosa remains almost normal. So mucosal margins from the gastrointestinal lumen often not clinically meaningful. And the pseudocapsule with one layer of serosa membrane may be an adequate margin for a resection of a GIST. Typically, they do not infiltrate adjacent organs. Mostly they do not. And we should always consider an unblocked resection with adjacent organs if there is a risk of a rupture of a GIST. And the potential risk factor for disease relapse is the tumor rupture. So while doing a surgery for GIST, we should be always careful not to rupture the GIST. And not all minor defects should be classified as a rupture. For example, a R1 resection, superficial capsule laceration, they should not be considered as a rupture of the GIST. And as we do in malignancy, the lymphadenectomy is the primary thing that we are concerned for. But while doing a surgery for GIST, lymphadenectomy generally is not necessary due to the rarity of lymphatic invasion. And it is reserved for only clinically positive nodes or pediatric GIST cases. And the principle of surgery in primary resectable GIST is a completely gross resection with negative margins, R0 resection, with adherent organ resection if at all they are involved, but mostly they are not involved in a GIST. Margins of 1 to 2 centimeter usually they are recommended, and surgeons should always try to avoid a tumor rupture. Whether it is laparoscopically done or robotically done, it is always discouraged in larger tumors. Probably in larger tumors, open surgery is probably far better than the minimally invasive. Careful exploration of the abdominal cavity for dissemination should be done, and a neoadjuvant treatment is ideally should be considered in patients who are having in place of having a mutilating surgery. So either laparoscopic surgery for primary GIST, yes, though laparoscopic resection continues to expand, there is absolutely no size cutoff for doing a laparoscopic surgery. And all the time, the standard oncological principles, whatever we maintain for open surgery, the same thing, even for any other malignant surgery when we do a laparoscopy, the same principle also we follow in while dealing with a GIST. The whole goal is the complete macroscopic resection and avoiding a tumor rupture. GISTs are soft and fragile tumors. They require extra care to avoid intraperitoneal seedling. And an extraction endobag is always recommended as we do in any other laparoscopic malignant surgery. And there is limited data for non-gastric GISTs, and it is a technically demanding procedure when it comes to laparoscopy. I remember there was a sizable GIST in the greater curvature of the stomach where we could not think of or were not possible to go for a wedge resection. We had to go for a sleeve resection. So, I mean, the planning of surgery in a dealing with a GIST on table probably is probably the best solution for any kind of surgical plan. Pre-operatively having a plan and the entire plan absolutely changes when you deal on table. So consideration of neoadjuvant therapy, yes, imatinib therapy should be considered for downstaging in surgically challenging cases. Surgery typically performed after maximal tumor response of around 6 to 12 months. Imatinib generally is stopped one day before surgery and resumed post-operatively. Neoadjuvant strategy is crucial in difficult tumor sites, for example, distal rectum, G junction, and less mutilating surgery with neoadjuvant therapy reduces the risk of tumor rupture as well as extensive blood loss. So when it comes to different organs, starting off with esophagus, esophageal cysts are extremely rare, making it difficult to provide a general surgical recommendation. High recurrence rates and morbidity and mortality associated with the surgical procedure. Enucleation is always preferred for smaller tumors, whereas esophagectomy is reserved for large high-risk tumors more than 9 centimeter size and those which are more invasive. When it comes to stomach, whereas a segmental resection is common for favorably located tumors, but gastrotomy is required for large endophytic tumors with a normal mucosal margin should be about half the tumor circumference. That is important, that the margin of resection should be about half the tumor's circumference, and we need to prevent stenosis by ensuring sutures as staplers which are perpendicular to the stomach's long axis, and open surgery is recommended for highly vascularized fragile tumors to prevent rupture, and one should always avoid enucleation or selling out methods to prevent peritoneal spread and gastric wall perforation. When it comes to duodenum, the tumors more than 2 centimeters should be surgically resected. Whereas R0 resection with 1 to 2 centimeter clear margin is the goal, but that's always not possible. It sometimes we may land up in a pancreatic or duodenectomy. It is recommended for larger tumors involving duodenal wall, pancreas, or close to the papilla mater. Wedge resection is suitable for small antimesenteric sided tumors, and limited resection is effective for small sized antimesenteric sided duodenal cysts, minimizes late and post operative complications. When it comes to small intestine, things are much easier. It's a segmental resection and is recommended approach for all small intestinal cysts. Colonic cysts are most common in the sigmoid colon, followed by the transverse colon, cecum, descending and ascending colon. Segmental resection is sufficient if adjacent organs are not infiltrated, and mostly adjacent organs are probably not that commonly infiltrated also in colonic cysts. When it comes to rectal cysts, options include laparoscopic transsacral resection, sphincter preservation, various surgical techniques like transanal resection, transsacral approach, TM, TAMIS, laparoscopy. All things can be possible in a rectal cyst. And in cases of emergency intestinal obstruction, a diverting colostomy with biopsy is probably a preferred approach. Unblocked resection of primary cyst is typically limited to one organ but may require extensive surgical treatment during emergencies like bleeding or gastrointestinal obstruction, and the examples include probably partial colectomy, distal pancreatectomy, and splenectomy in complex cases. Laparoscopic surgery offers benefits such as faster recovery, less blood loss, reduced post-operative complications, and early recovery, of course. So primarily they are applied to the gastric cyst with limited data on small intestine and rectal cysts. It is suitable for gastric cysts up to 5 centimeter according to NCCN guidelines. So what are the challenges in laparoscopic surgery? Difficulty in recognizing tumor borders, avoiding excessive manipulation in large or poorly located tumors. Wedge segmental resection is the preferred method, but partial or total gastrectomy may be necessary for larger tumors. Primary unresectable disseminated cysts. Primary treatment is systemic therapy with tyrosine kinase inhibitors. Tyrosine kinase inhibitors are highly effective, leading to significant remission in most patients, often enabling surgery that might be potentially curative. And resection of residual lesions post tyrosine kinase inhibitor remission, or in patients who achieve remission with TKIs, resection of residual lesions can be considered. Although not formally supported by clinical trials, observational data suggests this approach may be beneficial. Surgery is performed when remission allows for a potentially radical operation and aiming for a complete removal of residual disease. So surgical intervention for life-threatening symptoms, if it comes to severe bleeding or gastrointestinal obstruction, then we have to just deal the way that we deal for any other GI bleeding in the whether we go for some kind of interventional procedure or surgical procedure, that depends on the logistics, the surgeon's expertise, as well as the availability of the facility. So thank you very much for this opportunity, and it's a pleasure to be here for answering questions at the end.
Thank you, Professor Sahu, for this crisp and informative presentation. Our next topic is neoadjuvant therapy. Despite GIST being a cornerstone, surgery being the cornerstone of GIST, we generally, in many cases, land up with the locally advanced nature of the disease, and that's where we have to call in our peers. Dr. Sayan Kundu is a consultant radiation oncologist at Chittaranjan National Cancer Institute, Kolkata, and he will be speaking on neoadjuvant therapy in GIST, when, what, and how long the therapy needs to be given. Dr. Sayan Kundu, please.
Yeah, thank you. And I am honored to have that opportunity here today evening. And the topic of my presentation today is neoadjuvant therapy in GIST. When, what, and how long. So I think the most difficult part in dealing with a GIST patient is to actually diagnose the patient with a GIST. The treatment part is pretty easy. So my previous speakers have already done the hard work. Dr. Nirmala, Dr. Ramanuj, and Dr. Manoj Shau has beautifully explained about the different aspects of diagnosing GIST, and later on how to go ahead with the molecular markers. Dr. Shahu has already described about the different surgical techniques. My topic is pretty simple, and it's neoadjuvant therapy in GIST. As we all know, as a surgeon, you all know that surgery with macroscopic complete resection is the backbone of treatment of GIST. But sometimes it's difficult to achieve a complete resection or a negative surgical margin. And then comes the role of neoadjuvant chemotherapy in treating the GIST. So we should have a clear idea about the criteria of inoperability in case of GISTs. So basically, there are 4 or 5 criteria. Actually, the last criteria should be the first, when the surgeons think that the resecting upfront would have a margin positive disease. We should not operate and send the patient to medical oncologist for initiating the neoadjuvant chemotherapy. So marginally resectable GIST should not be operated upfront. Apart from that, most of the gastric GISTs are operable upfront. Anorectal primary GIST, if sphincter preservation cannot be done, the surgeon should opt for a neoadjuvant chemotherapy. Locally advanced disease in esophagus or esophagogastric junction should offer the neoadjuvant chemotherapy. And key duodenal or pancreatic region GISTs, where upfront surgery will lead to severe morbidity or the positive resection margin, should receive neoadjuvant chemotherapy. So actually, the backbone of neoadjuvant chemotherapy, whatever data we have, there is not so much data in treating GIST with neoadjuvant chemotherapy, but whatever data we have is mostly with the tyrosine kinase inhibitor, imatinib, as you all know. So basically, there are 3 or 4 major trials. One of the most important is the RTOG trial, the 0132, in which they actually took the KIT positive locally advanced or metastatic or recurrent GIST and were divided into 2 groups. The group A with the primary locally advanced GIST with a 5 centimeter or more tumor, or metastatic GIST with more than 2 centimeter tumor. They gave they were treated with preoperative imatinib with 600 milligrams per day for 8 to 12 weeks. The stable disease or the partial response patient, they underwent resection, and the progressive disease patients, they were off-studied and they were given the treatment of physician's choice. So the primary objective of the trial was progression-free survival with secondary objectives of response rate, toxicity, and overall survival. So as we see the progression-free survival, in all patients, there was around 80% of progression-free survival after 2 years. For the primary patients, that is the locally advanced GIST, it touched 82% level, and for the recurrent or metastatic GIST, it was around 77%. So more important is the achievement of the R0 resection rate, which was around 77% for localized GIST and 58% for recurrent or metastatic GIST. The only limitation of this study was the dose of imatinib. We generally don't give imatinib at around 600 milligram per day. Generally, it's giving at around either at 400 milligram or at 800 milligram per day for exon 9 mutations that has been already previously described. So this was the one of the first studies of the RTOG group, which was published in 2009. So coming to the next trial, which was a phase 2 study of the GIST, of the gastric GIST, basically. So the KIT positive histologically proven gastric GIST of more than 10 centimeter, they were given a 6 months of imatinib dose of 400 milligram per day for 6 months, and it was continued till 9 months. Surgery was done and followed by adjuvant imatinib for 1 year. So the primary endpoint of this study was very perfect. It was the R0 resection rate, which should be the primary objective in any neoadjuvant chemotherapy trial. Secondary endpoints are PFS, overall survival, and overall response rate. So if we see this study, there was a huge R0 resection rate of around 91% after 9 months of neoadjuvant imatinib. And 2-year PFS and OS were pretty high in the range of 89% and 98%. But the only limitation of this study was it considered only the gastric GIST, which already we know have a good prognostic factor. So the study took only gastric GIST, and it was a not randomized and one-arm study. So that was the only limitation. Apart from that, this study showed a huge R0 resection rate of more than 90% after 9 months of imatinib. This is another trial which was not published in a full paper, but it came as an abstract after the ASCO publication. It took the potentially resectable GIST, but it took of various size, risk, and location. So it took GISTs of all the locations of the gastrointestinal tract, and they were treated with neoadjuvant imatinib for 6 months. The R0 resection rate, now it came down to 71% because it took the GIST of all the sites. And R0 resection rate without tumor rupture was of 91%. So there are both pros and cons of treating with neoadjuvant imatinib for long duration. So if we treat patients with long duration of imatinib, say 9 to 12 months, we can easily achieve a high R0 resection rate. But if we treat for such a long duration, there is also a chance for potential for peritoneal metastasis, as it was seen in this trial, because some of the good prognostic factor patients, like exon 11 mutated gastric GIST, 2 or 3 such patients, they turned out to be peritoneal metastasis positive after around 9 months of imatinib neoadjuvant therapy. And this was the most important trial with from the URTC soft tissue group. It was basically a meta-analysis of 10 URTC sarcoma centers. Good number of patients, around 160 patients with locally advanced non-metastatic GIST, and they were treated with neoadjuvant imatinib. I'm sorry for this here. This was 400 milligram per day, and treatment was continued till maximum response. So they defined maximum response as 2 consecutive CT scan imaging, which did not show any further regression. So 2 consecutive CT scan imaging, when they did not show any further regression, the patients were taken up for surgery. And they showed a R0 resection rate of around 83% with a 5-year disease-free survival of 65% and median overall survival of more than uh, around 8.5 years. So uh, the importance of this study was that they did a subset analysis of the different sites of GIST, and they showed that the rectal and the gastric GIST, they had the best disease-free survival of around 83 to 88%, and the DFS was poor for the small intestinal or jejunal or ileal GIST at the range of around 50%. So, coming to the basic treatment approach, when we consider the treatment approach for GIST, the first thing is we need to see whether it is operable or not inoperable. So if we consider it as inoperable, we go for the neoadjuvant imatinib. So the first thing we need to see is the tumor mutational status, which has already been described beautifully. So the three or four subsets can occur. The patient's mutational status has not been assessed or unknown. The patient is KIT mutation positive. He or she is PDGFRA mutation positive, but not the D842V mutation. And the patients who are KIT and PDGFRA mutation wild type, not mutated. So even if the patient is KIT mutation positive, we need to see whether he or she is exon 9 positive or exon 11 positive. So if he or she is exon 9 positive, we need to start with a higher dose of imatinib of 800 milligram daily. If he or she is exon 11 or other mutations positive, they should be started with the standard dose of 400 milligram daily. So after that, we need to see, check the CT scan of abdomen and pelvis after around 2 to 3 months. So if the patient is responding to the TKI therapy or imatinib, we should continue imatinib neoadjuvant therapy for around 9 to 12 months. And after that, if he or she is resectable, the patient should undergo resection. And after the check CT of 2 or 3 months, if the patient is not responding to TKI, then subsequent line therapy for GIST should be initiated in the form of sunitinib or regorafenib. So coming to the dose and duration of imatinib, we should start with imatinib 400 milligram per day, as Dr. Nirmal has told that the mutational status report takes some time to come. It has a longer tag. So we generally start with the standard dose of 400 milligram per day. And if the patient turns out to be exon 9 c-KIT mutation positive, we generally increase the dose to 2 tablets per day or 800 milligram per day. Coming to the PDGFRA D842V mutation, it is not generally responding, they don't respond to imatinib-based therapy. The only neoadjuvant therapy which is approved by the European Union or ESMO is the avapritinib, but it is not US FDA approved. The optimal duration of therapy is not yet established. We should wait for the maximal response as per one consensus, which I have already told. The 2 subsequent CT scan does not show any further regression. Ideal duration is 9 to 12 months of neoadjuvant therapy, and it is better to avoid NACT for more than 12 months because most of the time it has been seen that it may lead to further peritoneal metastasis. Side effects of imatinib, we should know there are some basic side effects. The most important, as with all chemotherapeutic agents, nausea and vomiting. The unique side effect with imatinib is the ankle and periorbital edema with fluid retention. It may lead to pleural effusion, ascites, pulmonary edema, weight gain. As with all TKIs, it may have some diarrhea, myelosuppression, mild transient elevation in liver enzymes, and some skin reactions as with all other TKIs. So to summarize my talk, while approaching for treatment of a GIST patient, the surgeons and all should know whether the patient is operable or inoperable, whether they can be operated with good surgical margin or not. The mutational status should be known. Most importantly, the c-KIT, that is the exon 9 and 11, and PDGFRA mutation should be known upfront. And in PDGFRA, we should look for the D842V mutation, which is generally resistant to imatinib. The drug of choice and dose, I have already discussed. It is the imatinib, which is given as neoadjuvant therapy. Dose is mostly 400 milligram per day. And if he or she is exon 9 mutated, then we give a double dose of 800 milligram per day. Avapritinib, it's only recommended for the D842V mutated patients, but it's not US FDA approved. It's only approved by the ESMO or the European Union. We should look for initial response with CT scan of abdomen and pelvis at 2 to 3 months, to see whether the patient is responding or not. If the patient is responding after 2 to 3 months, we should continue neoadjuvant chemotherapy for 9 to 12 months. If he or she is having a progressive disease, we should change the TKI and go to subsequent lines of treatment. And we should watch for maximal response with CT scan after about 9 to 12 months. So with this, I end my talk and thank you all.
Thank you, Dr. Shan, for your crisp and to the point presentation. Because most of in our country we deal with locally advanced cysts, surgery is not the end point of our treatment. So there is a very well-established role of adjuvant therapy, and there is resistance to this adjuvant therapy where sometimes the relapse happens. So I'd like to invite Dr. Jyoti Ghosh, who is the Senior Consultant Medical Oncology, Apollo Multi-Specialty Hospital, Kolkata, for the talk on the adjuvant therapies of cyst and the risk. Over to you.
Yeah, thank you. So I'll just quickly go through the later part of the GIST management. I hope my slides are visible and I'm audible. So the first thing that we need to do is basically the risk estimation and adjuvant therapy. This is the first part that we'll be doing. So regarding some basics, so we need to understand who basically needs adjuvant therapy. So that comes with the risk stratification. And risk stratification estimates it primarily estimates the chances of recurrence. And based on that, we decide our treatment, whether the patient needs adjuvant treatment or not. This is one of the most commonly used prognostic model, which is used largely in US, UK also, which is a very simple model. You can just have this in your OPD and it can be quickly looked at. So this looks at the site, the tumor size, as well as the mitotic rate. And as you can clearly see that any tumor more than 5 centimeter and more than 5 mitotic rate falls in the risk group. So that is go for any GIST who has a mitotic rate of more than 5 and is non-gastric should be considered high. You can see all the higher mitotic rate patients are in a high risk group and they warrant the usage of imatinib. Also, majority of the trials have included intermediate risk in selecting for patients for their adjuvant treatment. But somebody who falls in the no risk or low risk zone, in that situation, you can actually do away with imatinib and just go for observation. And this is another NIH criteria, but this criteria is, I would say, inferior to the previous criteria because it does not take into account the primary site of the GIST, which is of utmost importance. And we have seen in our previous slide that the site significantly matters when it comes to race stratification. Another very useful tool that you can use is the MSKCC nomogram, which is very much doable in the OPD. So you just on the left side, you can see once you go to MSKCC nomograms, type GIST, you will get this page. So you just have to enter the size of the tumor and the primary site and the mitotic index. And once you do that and click on calculate, you will get a result on the right, which looks like the picture on the right side. So it gives you the 2-year and the 5-year probability of recurrence-free survival after surgery. And this is not exactly a tool to decide whether you want to give adjuvant therapy or not, but it helps you in prognosticating the patient. And this has got a very good visual impact, and it gains patients' confidence. Now, once we decide that the patient goes for adjuvant imatinib, there are primarily 3 initial major trials which have looked at the advantage of giving imatinib in the adjuvant setting. First one is the ACOSOG trial. This is a phase 3 double-blind study, 700 plus patients. 3 centimeter or more size tumors were included who were IHC positive for c-KIT. Imatinib 1 year versus placebo. Clearly, imatinib was better than placebo. RFS at 1 year was 98% versus 83%. Coming to the next trial, the URTC trial, again a randomized trial, 900 patients. This included the intermediate and the high risk group. Here, 2 years of imatinib was used in place of 1 year versus observation. Here also you can see that there is a wide separation of the curves. Definitely, 5-year RFS was significantly better. And coming to the most important study, the SSG trial, where patients were randomized into 1 year versus 3 years of adjuvant imatinib. So there were almost 400 patients, and patients were found, and the primary outcome was recurrence-free survival. On this right side, you can see that there is a favorable recurrence-free survival supporting the usage of imatinib for 3 years rather than 1 year. So the first 2 trials established the role of imatinib in the adjuvant setting, and this trial basically told us that we need to use it for 3 years rather than 1 year. Now, there are some practical problems. So many times we have this question in our mind, is there any role of molecular testing for deciding the adjuvant? Now, my colleague Dr. Shayan Kundu has told clearly that in the neoadjuvant setting, to rule out resistant clones or resistant subtypes, you definitely need to have the mutation testing done. But in the adjuvant setting, none of the trials have actually looked at the role of imatinib based on the molecular profile, because it was not very much advanced when these trials were designed. So there is always a confusion whether molecular testing should be done during the adjuvant, and any role of increasing the duration of imatinib for somebody who has already completed 3 years of duration. So coming to the molecular part, yes, some variants are inherently resistant to imatinib, like the D842V, or the SDH deficient GIST or the neurofibroma related GIST. These are the ones which are absolutely imatinib resistant. So in these situations, even if the patient is high risk, there is not much evidence that imatinib will work, and you can keep the patient under observation, or you can enroll these patients in the newer drug clinical trials. Also, if you find a KIT exon 9 mutation, you can go for imatinib at a double dose of 800 milligram in place of 400 milligram. And another thing that we need to remember here is that amongst all the exon 11 KIT deletion, imatinib is beneficial only in the deletions basically, and not in case of an insertion or a point mutation. So when you're looking at the report of exon 11, do not jump into imatinib when you just see the word exon 11. Also read the next line, whether it is a deletion, insertion, or point mutation, because it's not going to work in case of insertion or point mutation. Now, whom to avoid imatinib in the adjuvant setting? To summarize, the D842V PDGFRA mutation, the c-KIT wild type patients, and the PDGFRA wild type patients. Now, coming to the other question, whether longer duration of imatinib has any role in today's world. Well, this is a very recent paper which was published, which was discussed in ESMO virtual plenary in May 2024. It was an open label study, and the primary endpoint was disease-free survival. There were 136 patients included. And it was seen, surprisingly, that the disease-free survival was significantly longer in patients who received 6 years of imatinib versus the standard 3 years. Although there was no difference in the overall survival, but the overall survival data is immature. So once the full text of this publication comes, I think there will be some changes in the guidelines, and it might become actually 6 years of imatinib rather than 3 years. Now coming to the second part of my presentation, what are the mechanisms of resistance? Now there are many mechanisms of resistance. So hello? Yeah. So the primary mechanisms are the ones which we just discussed, the inherent mutations that are resistant to imatinib, and the secondary mutations are multiple. So the most common secondary mutation is basically the gene mutation that happens in the c-KIT and the PDGFRA. There was a Chinese study which concluded that 63% of the patients had mutation in the exon 13, 4.6%, 7% had mutation in exon 14, and 31% had mutations in exon 17, which led to imatinib resistance. Again, in another study, KIT exon 13 mutation and 17 mutation were one of the most common secondary mutations found. Another way of developing resistance is abnormal energy metabolism. So you can see there is a complex pathway which involves the ROS, HIF, GLUT1 pathway. So here also changes can happen in the in any of these molecules, leading to imatinib resistance. Also, the non-coding microRNA, they can also affect the effect of imatinib. Like, for example, the non-coding mRNAs, which encode for the PIK3C, AKT, MDM2 pathway, they can also have influence on the imatinib resistance. This is also, again, shows that there are some microRNA mechanisms also which can lead to changes in the imatinib sensitivity. And some oncogenic KIT signaling in the Golgi apparatus can also affect the resistance. So what are the options? So once we have a patient who is on advanced disease and is on imatinib and progressing, a very good option would be to do a rebiopsy from the newer lesions and look for the molecular profile of that tumor. Liquid biopsy can be an option, although it is not mainstream, not recommended by many authors, not recommended many guidelines. But in situations where a rebiopsy is not possible, you can go for liquid biopsy. There are a couple of papers. So one of these papers says that there is you can see that in the curve it shows the pickup rate for certain mutations in the liquid biopsy, and on the right side it shows the radiological progression. So there is, in this study, it was seen that there was a very good correlation of radiological progression with blood shedding of these specific mutations. So in such situations, you might consider going for liquid biopsy, but it is still not the mainstream. Coming to another part, that is response evaluation. Now, response evaluation, the standard response evaluation is through CT scan or MRI, which is the RECIST criteria, and we have the optional, that is PET scan. Now, what are the problems with PET CT in GIST? First is the cost. Definitely, a large chunk of our patients cannot afford PET CT. Second is availability. It's not available widespread. And thirdly, according to a paper by Dr. Choi et al., it was seen that 21% of the lesions which had a size from 1 to 4 centimeter did not demonstrate any uptake in the PET scan. And also, we all are aware that the biological aspect of responses is not like other solid tumors. So here you can clearly see that on the left side, it's a treatment naive patient. There is a lot of soft tissue component inside the large masses. There is central necrotic core, and when patients are given imatinib, which is a tyrosine kinase inhibitor, there occurs a very good liquefaction, reduction in the solid tumor component, reduction in the vascular enhancements also. So they basically form large cystic masses. This is how the response happens. And you can see that there is not much change in the size of the lesions, but there is significant biological response. So is there a better way to classify or quantify the response? Yes, definitely by the choice criteria. And this paper from Choi et al. Showed that there is a very strong correlation of the choice criteria based CT response with an FDG PET response, and both of them were statistically significant. Also, another paper which was quite interestingly named as should we desist using resist, at least in GIST. So 58 patients were included, all were evaluated by both the criteria. And patients who met the choice response criteria at 2 months had a significantly better response or outcome than those who did not. And disease-specific survival also correlated with the choice response versus the resist response. So this was the curve. So you can see that for both the disease-free survival curves, the choice responders had a far better outcome compared to non-responders versus the standard resist criteria, which is in the lower part of the curve. So clearly, these publication tells us that if we are using CT scan, we should go by the choice criteria. Otherwise, we go for PET CT. Now, coming to subsequent lines of therapy, which is a very complex area, so I'll just try to simplify. So these are the options that we have. We increase the imatinib dose. We go for sunitinib, regorafenib, avapritinib, ripretinib. Coming to dose escalation for imatinib, there was an European study, which showed that dose escalation led to 3 out of 133 patients partial response and 36 out of 133 are stable disease. So not much encouraging results. Another American study, 31% had some objective response. Mostly it was stable disease. And some retrospective studies have compared high-dose imatinib versus sunitinib. It showed that sunitinib is better than high-dose imatinib. So high-dose imatinib is not always the preferred option. Coming to sunitinib, clearly the curves reflect that there is definite effect of sunitinib compared to placebo. This was a study, phase 3 randomized trial, clearly significantly beneficial effect of sunitinib versus placebo. And it is seen that the benefit is more with exon 9, PDGFRA, and exon 11. Coming to ripretinib, this is a new drug, although there was a lot of promise, but it failed to keep the promise. So this was the study where 453 patients were included. Those who had a progression on imatinib, they were randomized into ripretinib versus sunitinib. However, ripretinib was found to be effective in tumors with secondary resistant mutations in the KIT exon 17 or 18. In contrast, sunitinib was more effective in those with resistance in the exon 13 or 14. So these exon mutations can decide whether you would benefit with the ripretinib or you would benefit with the sunitinib when the patient progresses after imatinib. But if you look at the overall population, there is no difference between ripretinib versus sunitinib when it comes to post-imatinib treatment. Coming to another drug, avapritinib, well, this is largely restricted for patients who have the D842V mutation. There was this Navigator trial where overall response rate was around 91% with a PFS of 34 months in patients who have this particular mutation. And it is also tested in refractory GIST. Again, a randomized trial was done. Avapritinib was compared with regorafenib, but there was no difference in the progression-free survival. And the response rate was 17% versus 7%. So there is some improvement in the response rate with avapritinib, but there was no difference in the progression-free survival. Coming to regorafenib, another effective drug, unlike ripretinib or avapritinib. So clearly a phase 3 trial showed benefit of regorafenib versus placebo and significant improvement in the PFS. One thing I need to mention here is that the drugs sunitinib, regorafenib were tested against placebo. However, the newer drugs are tested against either sunitinib or regorafenib because when these trials were designed, already the second line of treatment was established. So you cannot go for a second line placebo. So probably that is the reason why these drugs did not have any strong benefit over and above the already existing regora or sunitinib. So maybe either of these TKIs are good. And it's not like one TKI fares better over the other, but definitely some TKI fares better over doing nothing. So this is a flowchart that we need to follow for advanced disease. We need to look for the c-KIT and the PDGFR mutation status. If the mutation is positive, especially for exon 11, standard imatinib. For exon 9, imatinib 800 milligram. Other KIT mutations, we either continue imatinib or we can go for clinical trials. If it is PDGF mutation, D842V positive, avapritinib or clinical trial. If it is other than 842V, you can try imatinib, although response rates might. But if it is a KIT and PDGFR wild type, then it's a problem. You can go for sunitinib or regorafenib, but preferably you go for a clinical trial, and although that's unfortunately not available in our country. So I'll just summarize quickly. So one should risk stratify before deciding on adjuvant treatment. Imatinib is the standard adjuvant. However, it should be avoided in PDGF 842V. Now we used for exon 9. For the recent series is better than all of some but not you only worry about mutations. And avapritinib for 842V can be used. Ripretinib has not shown much promise. It's exactly same as sunitinib. And other targeted therapies can be used based on next sequencing like NTRK fusion inhibitors or BRAF if they are found to be positive, or in sometimes some situations if you find a strong MSI positivity or PDL1 positive, you might try immunotherapies, but all these have been only tested in very early phase 1 studies and not any strong evidence of using them. Thank you.
Thank you, Dr. Ghosh, for this wonderful presentation. I thank all the speakers for their detailed and exhaustive presentations today. The presentations have been quite informative, so much so that we have not received a single question in chat box. Dr. Vikas?
Yeah. So
we are ready with yeah.
We have any case discussion? Do we have any?
We are ready with few case discussions. Dr. Abhishek will be starting with the first one. These are real life scenario, the patients we have dealt. So the locally advanced cases only, not the primary upfront surgery ones. So what has to be done, how the therapy has to be taken, which either neoadjuvant or surgery or what drug, we'll be discussing that. Dr. Abhishek, first case.
Is my screen visible now? Is the PPT presentation visible? Hello. Am I audible?
Yeah. Just be a little bit loud.
Yeah. So can we see the screen?
Yeah.
It is visible.
Okay. So we'll start with some real life scenarios. The first one is the low rectal case. It's a quite a large one involving the sphincter complex, and there is no otherwise organ infiltration in the recent organ infiltration. So what is your take? I would like to ask Dr. Shan whether we prefer a neoadjuvant therapy in this case, or we ask the surgeon to look for a surgery.
Yeah, so if it is a rectal cyst in which you the surgeons would estimate that you cannot sphincter preservation cannot be done, or the tumor is involving the sphincter preservation, so you should opt for a neoadjuvant therapy. For how long? I have already discussed, for around 9 to 12 months, not more than 12 months. The goal is generally response based, and not duration based, because we tend to do response assessment CT scans at around 2 or 3 month intervals. So when subsequent 2 CT scans does not show any further regression of the tumor, the surgeons would go to operate the disease. So in this case, neoadjuvant chemotherapy in the form of imatinib should be given to this patient.
Thank you for the input, Dr. Shah. So it was a case it started with neoadjuvant mechanism. So I'd like to ask Dr. Jyoti Ghosh, what will be your primary investigation modality? Because it is a rectal guest, whether you will like to have PET or CT or MRI. Dr. Jyoti, are you? I think Dr. Jyoti is not reachable. So I'd like to ask Dr. Ramanan Mukherjee whether he would like to do a CT scan, MRI, or a PET for this type of large rectal test.
See, the first one will be now, as the questions are that when the initial assessment is done for a rectal tumor, will always be an MR because you need to assess the sphincter involvement in this patient. As it is a low rectal cancer, hence the sphincter preservation should always be the first of the top priorities that we should have. Number one. Number two. Now, the second line is that as the sphincters are involved, and this is a confirmed gist based on the immunohistochemistry and the biopsy reports, then NACT will always be the dictum that we will opt for. So for a response assessment, the initial part should again be the MR with a PET, because dependent upon the PET, your rest of the next assessments in the future will always be done. So it is usually PET which is done in conjugation with an MR of the rectum.
So do you want to add a PET CT for response?
Dr. Abhishek, your voice is not clear. It looks suppressed.
So I'd like to ask Dr. Raman whether you want to add a PET CT scan for response assessment of neoadjuvant therapy in this area.
No, see, CT scan is technically CT scan, the availability of CT scan in a clinical practice is much easier to get rather than having a PET for the assessment. So now dependent upon the location of the tumor, as it is the rectum, now, and it is expected that it is confined to the rectum only without any metastasis upwards or around the liver or any other retroperitoneal extension of the tumor. So probably if you ask me, yes, an initial CT scan of the whole abdomen, thorax and pelvis as a screening protocol should be done, followed by the later follow-up should again be probably based on the CT, or I will like to have an MR rather than the CT because MR tells you a better delineation about not only the sphincters but also the tumor edema, the tumor response in this rectum case rather than going for a CT. So for a rectum, I will probably be going in more with an MR for an interval imaging. PET, again, the lines are not very clear about what should be the outcome about or what should be the timeline about selecting PET for a response assessment, 6 months or 1 year is not that clear. But yes, if you are thinking about a clinical regression of the disease and you are thinking about doing a surgical procedure, say for example, an ultra low anterior dissection before you are commenting upon that, maybe the patient has a CPR done or a complete pathological response on imatinib, then maybe in these scenarios, PET will be an important point to distinguish. But still, if you ask me an interval imaging, I'll think about an MR rather than a CT in this patient.
Thank you, Dr. Raman, for your inputs. So I'd like to ask
I just want to interpret, Dr. Ramanuj.
Yeah.
If we are going for the initial assessment and you are saying that the
Uh-huh.
MRI is to be done in all cases, but I think if I prefer to do is a PET CT first, because if it is already a metastatic disease and I'm not going to operate that case, then there is no value of MRI at that moment. When I'm going to plan for any surgery, that time I can do the MRI, and PET CT is sufficient to rule out the metastatic disease. If it is metastatic, I'm going to start with imatinib first and not the surgery. Then MRI can be done on the later date. Is it not right?
Sir, I will probably beg to differ on this point. If you think about the role about and PET CT is again functional imaging. If you see the CT quality in a PET, well, number two, remember that we are dealing not with the stomach, we are dealing with the rectum, where millimeter matters and sphincter preservation particularly will be very paramount. So definitely at all trials done, MRI will be the investigations rather than a PET only. Number one. Number two is that a group of the tumors will not be PET avid. So that is another problem with a PET. Number three is that the initial imaging of you diagnosing a rectal cyst in the upfront case is very difficult. You see the report of a biopsy which comes to be a rectal cyst, you take it with a pinch of salt. You see, talk to your pathologist that am I really dealing with a rectal cyst or not? Because rectal cysts, believe me, are very, very rare tumors to deal
That's
with.
right.
Cyst does not occur very, very frequently in the rectum. So I will probably be thinking again, if you are thinking about the diagnosis to be a cyst based on the IHC studies, still, if you think about what is the anatomy or the T staging to be accurate, sir, I will think about it rather than think only with or rather than base all my thoughts with only an PET CT. Sir, I'll think probably doing an MRI will be the thing that I will be practicing.
What my point is, if it is in the PET CT, it is already proved metastatic. Then
Oh,
we are not going to operate.
right.
And in
Right,
that
right,
case,
right, right, right.
MRI is
So,
not
right. So,
required.
very sorry, sir, I did not get your question. So, if you are saying that, right, that there are around say 10 liver metastases or there are lung mets, then
Yeah,
is there any
then
role for doing an MR? No, sir. Those are those rare scenarios where, or I will not say rare, it should be a common one again. So, yes, you can omit out that MR in that case because you now have a evidence of a distant and M1 disease.
yes,
So then definitely the T staging or the M staging will not be of an important. The M staging and the follow-up of the M or the metastatic staging will be then an important issue.
yes.
But mostly in case of rectal cyst, we tend to see peritoneal mets. We don't rarely see liver or lung mets. So the uptake of peritoneal mets in a PET CT scan in a case of rectal cyst may be sometimes very low, or it may be very difficult to interpret on a PET CT the small peritoneal mets. So if it is a lung mets, gross lung mets or gross liver mets, PET CT is okay. But if it is a small peritoneal mets, we will stamp it as M1. But then to me, PET CT is not the ideal investigation.
But Dr. Sain, that peritoneal mets you will miss in CT and MRI also, isn't it?
No, because the quality of CT scan in PET CT is not so great. If we do a good quality MR, obviously it should be more than 1 centimeter, and by a good radiologist, I think it's possible to pick it up.
Abhishek.
I think I'll move on to the next question. Sir, allow me to share my screen once again.
Abhishek, carry on.
Yeah, I want to share the screen. Is my screen visible?
Yes,
Yeah.
that case one slide is visible. Yes.
Okay. So now there is a partial response. There is almost a stable disease with your given therapy in this case. So I would like to ask Dr. Professor Manas Sahu sir, what are the surgical challenges we face during this surgery of the rectal disc, especially the large?
Dr. Sahu is not here.
Okay, okay. And, the, uh, Dr. Vikas, you can take the question or Dr. Ramanujas for the surgeons here. So, what are the challenges at a large red patches? How to spin it? Because if there is not much response, as you can see in the picture, it's quite a large issue. To get the and then the partial response, the sphincter is still available. So, do you think you can save the sphincter in this case, or you want to go for a
See, I think now as a surgeon, now remember that the biology of GIST and the biology of adenocarcinomas are very different. So whenever you are talking about a GIST, remember that every GIST, particularly if it is non-metastatic, should be thought with a very strong curative intent. So if you are planning for an NSCT and if your first line of NSCT has not been working, so I think it has been with an expectation that you have done the mutational testing before you started with the NSCT. But still, if it is not working, then it is better again to think about a multidisciplinary team board. Think about whether your sphincters are more important rather than switching the patient or to a second line drug, which may or may not be affordable to the patient. So these are those, say, split line decisions that you need to take over. But if you ask me on a very blunt note, definitely GIST is a very in a stable disease, in a non-progressive disease, then you can think about a second line therapy. Talk to the medical oncologist for second line therapies. But if it is a progressive disease and there is a gradual involvement of not only the sphincter but other organs, like say the bladder, then I think an aggression should be shown, because just remember, as I've told you, size should be the most important parameter that determines the chance that it is metastatic. So it should be a dicey decision between the selection of the surgery between the patient who is going to have the sphincter being sacrificed versus the medical oncologist who can go in for the second line therapy versus the surgeon who has to decide or judge between the two ends, between what should be the ideal middle path in those patients who remain at a stable disease or non-responsive disease.
So I would like to ask Dr. Sayan and Kundu also that what do you like in the osteopathic setting? We plan at whether you we prefer one resection microscopic positive margin with a single speaker, or you will better prefer a APR with a zero margin for resection, which is a stable disease post resection.
No, Dr. Abhishek, definitely if R0 resection cannot be achieved without sphincter preservation, we should go for APR, because R1 resection is not the goal. Our goal is to achieve a R0 resection. So even if the tumor has not shrunk properly after 9 to 12 months of neoadjuvant imatinib, sphincter preservation cannot be done. The patient should be counseled and go ahead with APR. It's not prudent to spare the disease. R1 resection is not mm, good in any case.
Dr. Abhishek, as you have said that it is a still sphincter abutted. First, clinically, I just need to know whether the sphincter is functional or not. If the sphincter is functional, we have an option of the intrasphincteric resections also rather than going for the APR.
Yes, sir. A point taken, but the challenges we faced during this stage was this such a huge tumor to go for a plane below this tumor was a really play challenge. This type of large tumor was surgically we face that if you want to go beyond the tumor for intersphincter dissection, we have to dissect out the internal from the external sphincter. That is basically technically challenging. Theoretically, maybe it is easy, but technically, this large tumor hampers maintaining the pelvis deep down below the hip. So that we faced during the surgery of this case particularly. I don't know about others' experience. So I think
Oh, that's right.
you
The
can
last
highlight
tumor is
some.
whatever the tumor is there, it is inside the lumen of the rectum and not going outside because it's the sphincter abutting. So still, even intraluminal debulking, and then you can go forward for the movement, this intrasphincter resections. Because if the sphincter sparing is as equally important as the disease itself.
So I take your point. So I think just what we can get from this discussion is that a planned R1 resection should not be our goal. If it is an incidental R1 during histopathology, that is well accepted, but it should not be because just to preserve the function or the organ, it should not be planned R1 resection. I think everyone will agree. Then we'll move on to the next case.
Dr. Sayan Ghosh, Shine Kundu, sir.
Yeah.
One old paper is there of D. Matteo. It's a very old paper that R0, R1 rejection, there has not been much difference in outcome, but R2 is definitely inferior. So in these cases of doubtful and dubious areas, can a planned R1 be done? Will it have any effect?
In case of GIST, R1, according to that paper which you mentioned, R1 has not got any.
It's a very old paper. It's
Yeah.
of 2000,
But
2002,
definitely
something
for
like this.
any, but definitely for any cancer, GIST is ultimately a malignancy. So for any malignancy, we should try to achieve a R0 resection. So imatinib adjuvant is there, but definitely the chance of recurrence or distant metastasis goes up if it is R1 disease, even if we continue for 3 years of imatinib.
Okay.
We'll move on to our next case. So this is the gastric fungal mass, which involves the diaphragm and spleen. Now, we suspected that this equally, but it was both thick and pitiable wild type. So I asked to like to ask Stephen Imalo, what further IC you would like to do, and what will be your targeted nutrition, or will you directly go for ALS?
I think Dr. Nirmala is also not there.
Anyone to answer the question? Do you have a question? Okay. So I think we can skip this question or maybe this have been discussed in details about uh, the molecular panels and the IHCs. So we go to whether you would like to go for a new argument with this question.
Yeah, if it's a wild type, I will just check the PDGFRA mutation, whether that is the D842V mutated or not. If it is a D842V mutated, there are some evidence that avapritinib can be used. But other than that, if it is a wild type, generally imatinib does not work, and there is basically very low chance of using imatinib in this patient. So we should try to prefer neoadjuvant chemotherapy for this patient, those who are both KIT and PDGFR wild. There are some drugs, but data is not there to use it in the neoadjuvant setting, like refritinib or regorafenib or sunitinib.
So the last question, when you proceed for this surgery, now this lesion was affecting spleen, and I think as splenectomy we have a much more question. So whether the panel will have to have a spleen clearing or will it prefer to have a splenectomy process?
Hello. Hello. Now, if you ask me as a surgeon, as has been reiterated probably many times today evening, getting an R0 is the most important thing, particularly if it is a recurrent gist. So, in a that case in which you are again dicing between how to speed up the spleen versus um, getting an R0, I will probably be thinking about a spleen sacrifice or a splenectomy. Yes, I know that there are problems with a splenectomy, but again, the risk about disease getting recurrent and again a recurrent disease getting malignant is much probably more practical. We have a problem in hand rather than having a spleen related sepsis in future. So I will be thinking about doing a splenectomy. If can as part of the spleen can be saved, which is very say very impractical or say not very practical a solution, then probably maybe an attempt. But yes, on a stronger note, I will go in for a splenectomy with an RCD.
Thank you everyone for your I think where I'm already put out time, but like to end the case discussion here, and I'd like to over to the and any
Before we finish, we have some questions in chat box. Uh, Dr. Umesh has asked that what should be the interval between NSC and surgery?
so imagine it can be continued during prior to the surgery because it has shown that imagine continuing imagine decreases the chance of tumor rupture and it does not cause any acute immunosuppression. So imagine can be continued until the day before the surgery.
Great. Anything else anyone want to speak or any comments? And another question is there, recurrent disease should be treated with NSC or the upfront surgery? Dr. Ramanu sir,
Can you kindly repeat the question again, sir?
the recurrent disease, whether it should be treated with NSC or we can go for upfront surgery?
Again, see, I told you in the beginning probably that it depends upon there is a balance between you talking about anatomy and the biology. If it is a recurrence in such a place where it is very easy to take it out, and then your anatomical reconstruction or anatomical part of the surgery is easily done, then yes, I will like to go in for a surgery rather than thinking about giving a trial of a neoadjuvant. Whereas on the other hand, as would be done for the primary one, again, the biology of the primary disease will be one of the important factors. If it is a malignant disease to begin with, then again, you may need to consider, even if it is anatomically resectable, that whether the concept about giving a neoadjuvant and then again thinking about doing a surgery should be the point of contention. But yes, if you think about the ESMO guidelines of 23 till, we do not have that strong an evidence in a recurrent disease to think about giving a neoadjuvant therapy, see the response in a resectable disease, and then plan. So if you ask me on a bottom line, if it is resectable in an anatomically favorable part with an R0 margin, yes, I will go in for a resection. If it is not, then see the biology of the tumor at the beginning, see the mitotic rate and the size, and then think about planning a neoadjuvant.
Thank you. I think we have completed all the questions from the chat box as well, and it was really a nice discussion today.
One more question was there.
Yeah.
Mr. Dr. Umesh Raj has asked about the cost of mutation testing and which centers are doing them. Dr. Nirmala Banerjee, are you available? Science sir, can you take up this question?
Yeah, it's done at almost all standard labs, be it Core, Dr. Lal, and many. There are many in India, and also in most of the hospitals they do it, where they have the PCR or the NGS facility. Cost varies. Cost varies. If you give for only the kit and the PDGFRA, it costs around 12 to 15,000. If we do a NGS, it varies between 30 to 35.
One more question has been asked by Dr. Umesh. If there is GIST with peritoneal metastasis, what should be the plan? Ramanujam sir.
Again, now that's a tough one. See, if you think about peritoneal disease in GIST will be considered to be an M1 disease to begin with.
To make
Number
it
one.
more complicated, Dr. Ramanuj, is there any role of HIPEC in GIST?
Yeah, I understand that. So they are going to take it towards the HIPEC. Well, no, there is no direct evidence about being an HIPEC in a sarcoma or a GIST yet. But maybe in the coming times, people will think about. Remember that we started with only pseudomyxoma. Now we have gone up to the stomach and the colon very well. So maybe, yes, we do not have any evidence as of yet to talk about HIPEC. No. It will still be considered a metastatic disease. But yes, in the future, maybe with the improvement of more adjuvant drugs, a limited CRS will be an option.
Dr. Hussain,
Suppose
anyway, the
after
HIPEC,
giving around 9 to 12 months of CRS score drops down to 3 to 5. So will you give option to that patient for a HIPEC?
Yes, I think, yes, I will be giving an option to the patient, provided that it is a CRS in which the organs that are resected will have a lesser morbidity. And say, for example, if you have an extensive disease where the amount of the resection that you need, what amount of cytoreduction you are planning, and then proceed with this or the cytoreductive surgery. But yes, one important thing, the site of the recurrence that is there, that needs to be removed very well. So that is also an important point to remember.
Anyway, Dr. Sain, Kundu, for the HIPEC, we need the chemotherapy, any established chemotherapy to use in the HIPEC system. And for GIST, we have only the oral TKI is what we are using for the neoadjuvant or adjuvant therapy. For HIPEC, we do not have any established chemotherapy which can be used even for the trials for GIST. Yes, for the GIST in peritoneal metastasis, we can do the cytoreduction surgery, but not the HIPEC.
Okay. Okay.
Ramanus sir, one question.
Yeah.
If the patient is metastatic beforehand only, and we are going for imatinib therapy, and the metastasis, liver or lung metastasis, that disappears, and only the primary is left with, should there be a role of surgery in that case of patient?
So number one, I will ask my medical oncology colleague to answer that. Number two is that if you are thinking about
Dr. Idris,
marking
we are
the
running
site,
out of the time.
if you're thinking about, say, for example, there is a solitary liver mets. If you're thinking about putting a clip or a marker on that site and then to remove that marker again, as I've said, still no, we do not have an evidence yet to remove that. Maybe in a colorectal metastasis, again, so that becomes a very debatable or a dicey topic. In a GIST, no, I will not go in, even if there is a PCR or a pathological completion.
Once a stage 4, it's always a stage 4.
Stage 4.
Maybe in the future, there may be some very selected group of patients like gastric primary, exon 9, exon 11 mutated. So this very selected group of patients who attain a CR after imatinib-based neoadjuvant therapy might undergo a surgery in the future, but till that there is no available data for.
Thank you.
Will-
With this, we have to conclude the session today. We are running out of the time. And I'm really very thankful for all the faculties from the Kolkata who has joined us for this GIST discussion. And with that, I would like to invite all the delegates, all the surgeons in the World Congress of Endoscopic Surgeons organized with IAGS. And we have a special TUGSS symposium in World Congress of Endoscopic Surgeons in Kolkata, which is from 23rd to 26th October. We will discussing about the benign and malignant upper GI topics in this, where we have invited speakers from UK and from our Indian faculties as well. So everyone who are nearby and who can, please join us in TUGSS Symposium in Kolkata. And with this, we are completing 3 years of TUGSS India academic webinar. I'm very thankful to all my executive team as well and with all the delegates. Thank you. Thank you very much.
Thank you, everyone. Thank you. Thank you, everyone.